Are you guys ready? I'm going to do the introductions and then we can go ahead and get this kicked off.
I need a
Yeah. Well, welcome. My name is Patrick Walker with Galen Healthcare. Galen, best in class healthcare services IT. So all transition services, whether it be archival or application portfolio management to help organizations minimize their security risks, but also reduction in cost. Today, we're talking about the importance of informatics with Sal Rivas. He's not only with the VA, but he's a fellow Marine veteran. So welcome. Thank you. Thank you for having us.
All right, well, thank you everyone for coming today. Today I'm going to talk about the importance of informatics when implementing a pharmacogenomics program. So another thing I just want to highlight, I am an informatics pharmacist, and I'm in charge of the pharmacogenomics program at the Phoenix VA. So just want to talk about the importance of informatics in this arena. I think it was up. There we go. All right, I'm not going to read this all to you, but I just kind of after the presentation, I would like you guys to have a better understanding of the role of pharmacogenomics in patient care. This is, since we're all about innovation, this is a very innovative side of medicine as well. Kind of describe the data that's created from pharmacogenomics lab testing. Also describe the importance of the lab data to be in the electronic health record so we could utilize this data, and building clinical decision support using the data as well. And we also want to kind of, the main thing is the importance of informatics in implementing pharmacogenomics, but not only pharmacogenomics, really a lot of healthcare initiatives out there needs informatics to be able to roll out and utilize the information we have. So just want to give you a quick overview of pharmacogenomics at the Phoenix VA, or just the VA in general. We have a program that's called PHARM. It's Pharmacogenomics Testing for Veterans. It's a very unique program out there where it's being funded by a donation from Sanford Foundation. They funded $50 million to the VA, where 10 million of that is earmarked for the actual VA sites to roll out. So that's for not only personnel, for all the logistics and admin part rolling out. The other 40 million is to pay for the tests themselves. So that's one of the unique things, is there's no cost, which I'll talk about here. There's really no cost to the veterans or the VA health for the pharmacogenomics testing. So that's one of the biggest barriers out there for pharmacogenomics tests, is the cost of these tests. Even though tests are going down, the price of cost are usually about $100, $150 now. It used to be $500, $600 per test. The nice thing about this, it's a panel, so we're testing 11 genes with this panel, and we're not testing anything beyond that. So a lot of questions I get, are we testing, am I predisposed to diabetes, hypertension, cancer? We are not testing any of that. We're strictly testing your genes to see how you metabolize medications. And we are using evidence-based, which is Clinical Pharmacogenetics Implementation Consortium. They provide the guidelines for pharmacogenomics. So one of my colleagues kind of drew up this picture to give us a visual of why pharmacogenomics. So if we look at this, there's a study out there that shows, just looking at 12 genes out there, there's way more than that, but just looking at 12 genes, on average, 97% of us contain at least one variant that shows that we may have may impact the way we metabolize a medication or response to a med. So 97% of us, if we just look at 12 genes. So that's what this picture kind of shows, that's the population. So when we have a potential impact of drug response, it could either mean that it could be toxic. So you just taking the normal recommended dose may cause toxicity. You may get sick from it. Or the big one is just not beneficial. So sometimes you may hear people like, oh, that dose doesn't work, I need double the dose. Well, this could explain why you might need a double dose, or why you need more medication, or why this doesn't work for you, or why do you get sick from it. So that's kind of what the two sides, either toxic or just not enough medication. So I just want to show you how this impacts and how it works. So one example I'm going to give you is citalopram. This is an antidepressant. And so citalopram, for normal metabolism, it just kind of breaks down to inactive form. That's the norm, just looking at it normally. Now, if someone has a decreased metabolism, it's going to stay the active form a lot longer in the body. So the inactive form is going to be decreased. So that's where you get your side effects, because you have more active form than a normal metabolizer. Then on the other side of that, we have increased metabolism. So if your body is actually metabolizing the medication a lot faster, this is when it's not effective, because you're taking the medication, but your body's metabolizing and breaking it down to inactive form. So that med's not going to work for you. That's when people say this dose doesn't work, I need double the dose. That's what happens. So these are some of the implications that I pointed out. So possibly no response at all from the medication because of the way they're metabolizing it. Time lost for changes. So if we go back to that antidepressant, when a patient gets prescribed an antidepressant, it could take 4 to 6 weeks until a provider decides that this dose is the right dose or the right med. So it takes 4 to 6 weeks for it to take action. And then the doctor reevaluates and says, do I need to increase it, decrease it, change the med? So that's 4 to 6 weeks wasted. So if we knew this information beforehand, then we could give them the right med, the right dose the first time. So time lost by changing medications, increasing the dose. Because honestly, some of this is guesswork, right? Like this is what's recommended. Let me start you on this. Let's try, let's see if this works. And then keep going from there, increasing, changing meds. So you got time loss from changing the dose, changing the medication. And then the other side of it is possible adverse drug reactions, because your body's just accumulating and it could be toxic for you. So I promise we'll get to data here soon. I just want to give you some background about pharmacogenomics. And it kind of opens the door for 2 questions and kind of 2 schools of thoughts for pharmacogenomics. Do we do reactive testing or preemptive testing? So reactive testing is I give you drug A, then it's not working for you. I don't know what to do. Let me just do a pharmacogenomics test. Let's see if this gives me information to help me guide the next treatment. Preemptive testing is like, let's get your pharmacogenomics information into the record. So when I need to prescribe you a med in the future, I can make the right choice, right med, right dose the first time. So that's what preemptive. The only downside for preemptive, especially outside the VA where all this is being paid for, is the cost, right? So a lot of third-party builders don't want to pay for a lab that doesn't have an indication. Why are you ordering this lab? So pharmacogenomics is very unique that it's lifelong information. It's not just one lab and then I make a change, check the lab change. No, this is your genes. So it's very difficult to get third party to pay for it just because there's no indication tied to it at times. So sometimes they'll pay for one gene because you're going to start on a med that's specific for that med, but it's hard to get a panel from third party builders. But good thing the cost is going down. Like I said, it runs about 150 to 200 depending where you're getting it from. But you have to make sure it's a reliable lab as well. So that's the issue of preemptive. But my goal is to have preemptive testing nationwide, all VAs, every VA. I'm focusing on Phoenix. That's where I'm at right now. So with preemptive testing, like I mentioned some of the challenges. The other challenge is data. Now we get to the data part, right? Like that's why I came for, not all this medical talk. So then we have the genomic data in these reports. What are we going to do with this information? So preemptive testing, we just have all that information there, but I'm not really making a decision at this time. So how do we manage this data and how do we create tools to make it useful? So we want the ability to provide it to the clinicians when they need it. So when it's most useful, we want to make sure that data is available. Because I could have ordered this years before a prescription was going to be made for a patient. So how do I make this available for the clinician when it's useful? And then just over the lifetime of the patient, like I mentioned earlier, this is lifetime information. The only time that this information would change is if you get a liver transplant, because most of these enzymes are created in your liver. So if you get a liver transplant, the genes of the donor are different than yours. So you may have to, and now they actually test the liver before you get the transplant at some facilities. So they could give you, because one of the medications they give you for a transplant is to not reject the liver, is actually managed by one of these genes that we test. So then we could make sure that we give you the right dose so you don't reject the liver. So that's the only time where that information would change, is if you get a liver transplant in your lifetime. So this is, you may not be able to see it, but I just want to give you guys a quick example of all the data available in one of these reports. So you see all these different pages. So there's a lot of information. So one downside to the program that we have at the VA, since we're funded by this foundation, they pay for the testing, so we have to send it to their lab to get tested. Unfortunately, we don't have an integrated system where we could get their data as discrete data electronically. So what we get sent is this in an electronic PDF. So PDF is just a bunch of words, right? Like a Word document. So it's very difficult. So early on, we're like, how can we make this discrete data into the EHR and the VA system? So just wanted to show you all the information we are trying to translate it. Now, why do we want this discrete data within our EHR? We want to be able to build clinical decision supports because these are very important, like we mentioned earlier, for preemptive testing. Because if we have the data within our system, then we could build tools for patients actually for the providers to show them the information when it's needed, when it's most useful. So if we put the discrete data into the electronic health record, then we could build tools that could retrieve that information for the provider when they need it. So one example of a clinical decision support is when let's say a patient got the lab test done 2 years ago, and then the patient now has depression, the provider wants to order a medication for the depression. So it's 2 years after the test. So when they order the test, we would like it to just pop up and say, hey, this patient is a poor metabolizer. You should probably consider increasing the dose or changing to a different med or avoid this med or lower the dose if it's toxic. So that's the type of clinical decision support we want to be able to build. So then the provider gets that information right before the patient gets prescribed that med. And those are the tools that I'll describe that we have done as well. So the big challenge is the PDF report that I was mentioning. So I want to kind of go back to the Pharmacogenomics data. This is really the important information that you see here is the gene and the phenotype. The phenotype is what tells you what type of metabolizer the patient is for those meds. This is our actual panel that we use at the VA for the Sanford Health Panel. It's 11 genes, and it tells us what type of metabolizer the patient is. So our challenge was, how do we translate this data into the EHR to have discrete data and manage this data to create tools with the data? So one unique thing we have at the VA, and I know it's unique to the VA because we're also, as you guys might know, we have Cerner integration too. So we've been kind of battling back and forth to try to get the same feature included in it. We have what's called health factors. So we have health factors within our system. So all I want you to think of them as data markers. And we'll zoom into this on the next slide to see a little better. But health factors are just data markers within the system. So that way we can mine that data and we can use it in either tools, in reports, in dashboards. So it becomes discrete data in our system. So the process that we came up with is we created a note template that we just look, as you can see here, kind of a pop-up on this side over here. That's the report from Sanford Labs. This is a note template within the EHR. And we actually have a coordinator that has to match these to add it into the system. So then they put in the phenotype, and then each of them get a data marker attached to it. So here's a closer look. So if a patient was a CYP2C19 ultra rapid metabolizer, you'll see the data marker health factor here gets put in the background. So this is all behind the scenes. This is added to the EHR, is added to the patient's record. So now we have these markers behind the scenes to be able to use for clinical decision support, for reporting purposes, to see how many patients are a CYP2C19 ultra rapid metabolizer. So this is the current process that we have. So now that we have usable data in the electronic health record, so we started with the PDF results, then we put that in the electronic health record using the health factors. Now we could build clinical decision support with it. Now we can build reports from it. So if we want to see how much of our population are poor metabolizers, like what do we have to focus on, we can start doing that information with those data markers. So I just want to show you an example. So this was our first clinical decision support we built. There's a lot more that goes behind the scenes to build it, to actually look for these data markers. but a basic one is a tramadol codeine interaction example. So the first one we built was a tramadol and codeine alert. So what it looks for, it's just a logic we built behind the scenes. It triggers when a provider orders a tramadol or codeine prescription, and then it goes behind the scenes, looks for the health factor. Does this patient a CYP2D6 form metabolizer? Yes. It finds that marker, then it comes back with a response, and then it displays a alert right there for the provider. So now we have discrete data that we build a clinical decision support that can inform the provider, hey, this patient may not react properly to this med, either need a higher dose, lower dose, or maybe a totally different drug overall. Oh, kind of covered some of it there, the header. Do apologize. So this was just kind of the current ones we have up there. The top ones is 2 cancer agents. In the pipeline, we have some antidepressants, the SSRIs. We also have NSAIDs that we're working on, same type of clinical decision support right now, because we have the data from the Pharmacogenomics panel. We just don't have the clinical decision support yet built. And we also have statins that we're building, clopidogrel, and ondansetron as well. So especially the clopidogrel, that's a big one in the cardiology field. So that one prevents you from getting any clots. So and the way clopidogrel works is it has to be activated to the active form. Just taking clopidogrel by itself and not getting activated, that's actually the inactive form, and it has to be activated to work in your body. So if it's not getting activated, you have an increased risk of clots. So that's where you can get a stroke. That's what heart attacks, how they happen. So those are things that patients get put on Plavix, clopidogrel, same medication. So if we're not able to tell a provider that this is not going to get activated in this patient, we can't decrease the reoccurrence of these cardiovascular issues happening. So this is a quick example of just showing you that now that we have these data markers, we could build reports and see the percentage of patients on their CYP2D6, what type of metabolizer they are. And of course, we have much bigger reports and dashboards now to have the demographics of the patients to get a better idea of our patient population. I think that was pretty fast. I do apologize. So just kind of the importance, summary of the importance of informatics. I'll give you more time. So informatics really holds a critical role in pharmacogenomics, and really I would argue in any healthcare initiative that we roll out. I mean, most people, except people in this room probably, but most people don't think about all the informatics, the data, everything that takes to roll out these initiatives or to take care of these patients. It is really important so we can build these tools, manage this data behind the scenes, to be able to put in this data in a usable form so we can build tools off of it, and then so they can consume the data in the appropriate time and the right format. So that's why it's really important for us. So one thing that I was in informatics before pharmacogenomics. So then when I started getting into pharmacogenomics, I took a pharmacogenomics certificate through one of the pharmacy organizations. And I was surprised that one whole module was dedicated to informatics for pharmacogenomics. I was like, oh, wow, this is just for me. I'm a pharmacist, informatics, and pharmacogenomics kind of all tied together now. So it is, and that's kind of why my talk is mostly in pharmacogenomics, because that's what I specialize in as well. And I feel that informatics is really important in our healthcare system. So any of our clinical decision supports we build rely on informatics, data management, how the data flows. And we also bring creative solutions, just thinking about the solution that we came up with there, where we're like, we have this PDF, but what do we do with it? So then we had to come up with a solution to be able to put that data into the record so it could be consumed. So here's some future states. I know a lot of people are probably like, why are you still doing PDF? Unfortunately, there's no linkage between these labs to the VA. So that's why we do have a test site within Washington, D.C. VA that we're trying to get that data transmitted electronically. And since we got them the system to be able to do that, and then they're going to become a hub, and we're going to have spoke sites where they'll transmit the data to the appropriate sites. Because unfortunately, the way the VA works is every system, every database for each site is separate. It's semi-integrated where you can read the data, but you cannot write at all sites. So each one has their own data set within each site, which in each location. So we're building little tools that we could dump all the data from the Sanford lab to this other BA as a hub, and then spoke and send those data sets to the other sites. So that's kind of one of our future goals, which we tested once already, and it's gone successful, but we're still doing some tests to make sure it comes back accurate. So we are going to start beginning to adjust these clinical decision supports to not only look for health factors, but now look for discrete lab data as well for the results. So the other tool that we're actually working on, and I think it works a lot better for clinicians, is building a tool that they can use while they're working up the patient, while they're trying to decide what medication. Because if we think about the example of the clinical decision support we have now, that's all reactive because the provider saw the patient, worked up the patient, you have this disease, I'm going to prescribe this med, I go to order this med, and then it pops up, wait a minute, I just spent all the time figuring out what med you want, now it's telling me that it's not good for you. So what we want to do is build a tool that they bring up a note. It has all the recommendations. They select the disease state they're working on treating, and then it will tell them, do not do these meds, or try, if you're going to try this med, do a higher dose or lower dose. So that way they could use that information to consider what they're going to prescribe instead of making a decision and then going back to the drawing board. So we're building that type of tool so the providers have it during workup. And then the plan is to increase our gene panel. When we first started, we only had 8 genes. Then we went to 11. And the plan is we're hopefully going to go out by the end of this. We're going to go up to 18 by the end of this year or early next year. So I'm just one person in the team. I'm in charge of the team, but it takes a team, like we heard earlier in the earlier talk. I mean, it takes a whole team to be part of this. So I have partners at the University of Arizona. We have a huge team at the Phoenix VA as well. It consists of pharmacists. It consists of MSAs, physicians. We also have our what we call our clinical application coordinators, the ones that build our systems, our reminder dialogues, our clinical decision support, our templates within our system. We have personnel. You'll see people from lab. We have to work with them closely as well. I mean, it's a good sized team. I probably couldn't fit them all on this slide, but this is the core team that we have. Thank you. Any questions, discussion? Yes.
Good presentation. Appreciate you going through the whole thing. I remember this technology what a great idea. There were so many insurance companies that didn't want to cover a test because they were just like that's a provider, which that's money. So the question I had is, are you guys also analyzing outcomes of this as far as seeing how many patients are having that side effects and more? That's the right drugs being chosen. I would assume that kind of data is value that data would be missing to insurance companies that could actually.
Correct. So that's our long-term goal, to look at those. We've been live probably about almost 2 years now. So we're trying to ramp up testing so we can have that endpoint data to see how many patients have benefit, how the ADRs have decreased. One thing we are evaluating right now is everyone that has a test, we're comparing, do they have an ADR, adverse drug reaction or allergy documented for one of the meds on the panel that we could have avoided. So we're trying to show that as of right now, because that information is already there. So we are trying to write up and look up, can we avoid these issues? Maybe it was admission to the hospital because of this med, if we had this information prior. So we are looking at that information. Good point. Yes, sir.
In your strategy to actually get better to take the test, how is that information?
Yeah, great question. So we posted things on our Facebook for the Phoenix VA. We haven't posted throughout the facility. I mean, we started this before COVID, and then once COVID hit, fortunately, a lot of inbound was reduced quite a bit. So now what we do is we're focusing on clinicians. So we're going to either the clinical pharmacists or the primary care physicians and saying, can we reach out to your patients before they come see you? So I have a coordinator assigned to my program. All she does and when it comes to that is she actually outreaches and calls the appointments for certain doctors. We just pilot certain providers for that, but calls those patients and let them know, hey, we have this program. Would you be interested in getting this test? We can place the order now. Just come to the lab, get it. So that's the kind of outreach we've been doing. Yes, sir.
I'm just curious, Sal, the team that you have, really impressive. How do you get this? That passed.
Yeah, so it really started with myself and Dr. Abzangan, which is the president of HIMSS as well. Kind of him and I brainstorming this project. And then we started, we had connections already with the University of Arizona. So that's where we got those two folks. And we just talked to them about this project we want to start. So we got them involved. And then naturally we had to get lab involved because it's a lab order. So then luckily I already had a connection with the lab from previous projects. So I was able to just talk to them, bring them in. And then my clinical application coordinator that I've worked with for years as well. I think it's just the relationships I already had embedded was a lot easier to bring the team together. Just from other projects and my outreach within our organization, I think made it a lot easier just to bring everything. Just because like everybody on this team, we've collaborated on one project at one time. And we just worked together well. So it was easy to bring everybody in. But it's just, yeah. This is just a small part of our team. It keeps growing.